Hi, I'm Lorelei Day with the City of St. Angelo. I'm here with Doug Schultz, Chief Medical Officer at Shannon. Hi Doug, thanks for being here with us today.
Good morning, glad to be here.
So we're going to be talking about COVID-19. Can we start off by addressing how Shannon when did they first start actively planning for COVID-19 and what major changes took effect?
Yeah, great question. So, we had the lucky situation where we could see what was happening on the East Coast and West Coast early on. So we were able to start planning, and really in early March, late February, early March, we started planning on meeting to have action plans put in place to go forward. And one of the first things we did was Shannon On Demand, which is a telemedicine platform, so patients could go on there and see if they had the symptoms and be sent to the right place for testing or to be cared for. So right off the bat, that was one of the first things we did. The second major thing we did really was form a physician task force made up of specialists, and that was really an amazing group. I want to call out two names in particular: Dr. Kenneth Perrett, who's our pulmonologist director at ICU, and Dr. Michael Wood, who's the head of our hospitalist program. So what they did was keep in contact with some of the major medical centers across the United States, in New York, New Orleans, Mayo Clinic, etc., to get the latest recommendations on how to treat these patients that came in. So when we did have patients start to come in, didn't have a lot of them, but we did have some that were pretty sick in the ICU. They were able to use the most up-to-date methods, and were very innovative. In fact, one of the pretty cool things they did was they set the ventilators and the IVs up outside of the ICU room, so you didn't have to go into the room to make the adjustments, and the nurse could give the medications outside the room. Now, people did, of course, have to go in the room, but then they had to gown up and everything. But you could stay outside the room and manipulate the ventilator without entering and gowning up and all the protection. So that was a very innovative thing to do. And of course, they were using other techniques that improve the patient's chance to recover.
How would you say that COVID-19 has affected healthcare in our community?
I think it's affected it in many ways. The number one thing I've seen is that, there was a lot of, stay at home, don't go out. And of course, the governor shut down elective surgery to make room for more bed space for COVID patients, as well as save on personal protective equipment, which is a good call and the right thing to do. But what it did was cause everyone to stay at home. And so, the other diseases are still there. So we still have heart disease, high blood pressure, cancer, strokes, etc. Well, those people were getting care, and it just kind of stopped. And mainly because they were just kind of scared to come in. And so really, I think that's the thing I've seen. All the preventive care kind of came to a halt. So getting screening colonoscopies, for example, looking for cancer, that came to a halt. Mammograms for women. So all those things need to get back in gear, because those things are still there, whether COVID is here or not. And those people still need their care, especially with chronic conditions, which of course makes them more susceptible to this virus in the first place. So we want them to get their care and get the preventative care as well, so that if they did get infected with this virus, then hopefully they would have a better chance.
So since the governor has loosened some of the restrictions, such as elective surgeries, would you say that you've seen an increase in patients coming to the hospital since that?
Yes, as soon as the governor lifted the restriction, we had already got in touch with the patients and were ready to go. And so, definitely we're getting patients in, getting their operations that they needed to have. People are coming back now and getting seen in the clinics. We have we did start telemedicine early on when people were staying at home. And we were already doing it to some degree, but we had to really ramp it up fast. So we ended up using multiple technologies like Zoom, Skype, Facebook, FaceTime, Viber. There was many different platforms, and some worked better for some patients than others. And it was kind of really an amazing thing to see how well the doctors and the patients did with this telemedicine. I mean, you can't do everything over telemedicine, obviously, but you could at least see the patient and have a visit with them and see how they looked and prescribe their medications and adjust their medicines, things like that. So telemedicine became a major way that people got care during that time.
With telemedicine, reserving bed space, things like that, is there anything else you'd say that Shannon has done to adapt to treating these COVID-19 patients?
Well, I mean, to actually treat the patients, like I say, we're completely prepared for that and have all the expertise necessary if we have one. And the ones we've had have done well. We did have one person, that didn't make it, but it was an elderly gentleman who had a lot of chronic conditions, but everyone else has recovered and been able to go home. A lot of the patients we have had that have COVID were not sick enough to be in the hospital. So they stay at home, and we have a care at home program that we started, which is also innovative, where a nurse would call them each day, and then a nurse practitioner also would call them, basically check in on them and see how they were doing and whether they needed to be seen or not. And so they were monitored very closely. Some we even monitored with technology, with Bluetooth technology, like taking their temperatures and blood pressure, things like that. So some pretty good innovation in that realm with those positive COVID patients.
Mm-hmm. Let's talk about testing. There's a lot of different information out there about that, and I think there's some confusion as well. Can you address what different kinds of tests there are and what you think people need to know about it?
Yeah, there are really two main types of tests. The first test is called a PCR test, which is basically looking for particles from the virus itself. So if you have the virus in you and we do that test, so that's a nasal swab, then we can see, okay, you have virus in you right now, so you're infected. And that's the main test that's being done pretty much everywhere. There are limited supplies on that, so the CDC has made recommendations on who to test and when to test them. And it's changed a little bit over the course, but right now they've divided it into what they call high priority and priority. So two levels basically, with high priority being people in the hospital. So they're sick enough to be in the hospital, that goes first. And then the second part of high priority is a healthcare worker who is sick, or a first responder who's sick, has symptoms of COVID. Those are high priority. The priority are the general population who have symptoms. And so those symptoms are, you probably know those already, everybody's heard of them, but cough, shortness of breath, fever, chills, body aches, sudden loss of taste and smell, and now they've added GI symptoms to that as well. So that's a priority, but the highest priority go to the hospitalized patients. So that is the actual test to see if you have the virus right now. Then you have what's called antibody testing. That's theoretically to see if you maybe had the virus in the past and now your body has made antibodies to that, which would be the normal thing that would happen. The problem there is those tests are not, many of them are not FDA approved right now, so we don't really know how accurate they are. There could be a lot of false positives or false negatives, and so we don't really, the CDC is not really recommending antibody testing right now because there's not good science behind what we would actually do with the results. Mm-hmm. So for example, if you were positive right now, if we tested you today, oh, you have some antibodies, are you suddenly going to stop wearing a mask or suddenly start hugging everybody? No, probably not. Mm-hmm. So you're not going to do anything different. Mm-hmm. And we also wouldn't know, you may have a level of antibody which is not safe. Maybe you need a higher level. Well, we don't know what that is yet. So, and there are other coronaviruses too. There's many common cold coronaviruses as well. They cause antibodies too. So the antibody test could be picking that up, not the COVID-19. So there's a lot of more. We need to learn more about this antibody testing before it's useful to us. So right now the main test is the actual testing for the virus particle, and that's what we are currently doing.
Now, with relatively low numbers of positive cases in San Angelo, can you talk about what has been attributed to that? What do you think the community has done to help?
I think it's a series of or multiple factors really. So if you think about it, New York City, we don't have subways, we don't have the tremendous density of population that they have. And so here we are in West Texas where we're kind of spread out, right? People drive their own car, so they're kind of already naturally social distancing, just in their normal day. And so I think that we had that working for us. And then we had, like I say, we had the advantage of being able to prepare by watching what was happening on the East Coast as it progressed. And even looking at Texas, you can see the more dense parts of the state, Dallas-Fort Worth area, Houston area, are the more hard-hit places. So I think that is a big help to us because we have San Angelo itself, but the surrounding area is very rural, and there's not a lot of people in that space in those counties that are all around us. So that I think is a crucial aspect of why we weren't hit very hard.
So what would you say is next? Do you think there's going to be a surge in cases, positive cases?
If you look at the history of some of the other viruses that have hit pandemics, global pandemics, for example, the Spanish flu in the early 1900s, 1918, 1919, that virus, it was a lot like this. It spread very rapidly. It was a flu virus, but still spread very rapidly, was very deadly, and then it kind of ran its course and dissipated. Mm-hmm. And so I think there's no reason this is just another virus, so it should be similar in that it will have a peak, and then it will go down, but then it may it'll probably return because everyone doesn't have immunity to it yet. And so I think we'll see a waxing and waning of it for a couple of years, and then everybody sort of gets immune, and it won't be here forever. But there'll be low levels of it probably this summer, cases here and there, and then it'll probably pick back up in the fall. I know a lot of Dr. Fauci has espoused that as well. I mean, we don't know, of course, but it's the typical. A coronavirus, it will probably follow that kind of pattern. Mm-hmm. But by next fall, hopefully we'll have more tools in our tool chest to fight, be it drugs or some types of other treatments, potentially a vaccine at some point. I feel strongly there'll be a vaccine, and then we can start vaccinating people, and that would be something they couldn't do back in the 1900s with the Spanish flu. That we can do, so that would be helpful.
Absolutely, I hope so. Mm-hmm. All right. Well, is there anything else that you'd like to add?
I just want to shout out to all our nurses and doctors and staff and all the people that work in our health system, because this is a tough deal. It's contagious. You worry about your family. You come to work and you worry about going back home. So. They've showed up to work every day, and they're helping in the fight on this. So that's been good to see.
For more information about COVID-19, you can visit cosatx.us/COVID-19.